Hi, everyone. My name is Naomi Dempsey. I am a hematologist oncologist at the Lynn Cancer Institute in Boca Raton, Florida. And I'm pleased to be here today to speak with you about shared decision making in oncology, which I think is something that we all feel that we do on a daily basis and is a really important part of our jobs. But hopefully there's something more that everybody can learn about how to do this effectively with your patients. So our objectives today are to look at examples of when shared decision-making is useful in oncology, describe the process of how we can really effectively incorporate shared decision-making into our everyday practice, talk a little bit about using patient decision aids, which patients oftentimes find very helpful, and to evaluate the patient-reported outcomes from their experience with shared decision-making. So there's a lot of reasons to perform shared decision-making in oncology. We all know that cancer care is extremely complex, even for oncologists ourselves or for physicians who develop cancer. They find cancer care to be very complex, let alone for patients who maybe have not had a lot of contact with the medical system before, and now they're learning all new things with a cancer diagnosis. Oftentimes there's a lot of different options available to patients, and we don't have data that tells us what option is better than any other option. And sometimes, as we all know, we're never going to find out which option is better than another option because that trial will never be done. So really that puts the ball in the patient's court about which option they prefer, and they really need our help to be able to make a good decision. Shared decision making leads to improved patient satisfaction. And that's really their experience with the healthcare system and with cancer treatment in general. So their satisfaction is really what colors their entire experience of a cancer diagnosis and treatment. They will have improved adherence to the treatment plan if they felt involved in the decision and they're invested in the decision because they played a large part in coming to that final decision. And this approach can help to reduce healthcare disparities, which is important to all of us. Shared decision-making is a part of patient-centered care, which the Institute of Medicine has as one of its highest goals for high-quality care, is that care is patient-centered. Patient-centered care, shared decision-making is just one part of, but other important parts are inclusion of family members, both in care and in decision-making, in sharing all of the information with the patient, of making sure that their goals are directing the care overall, and that the patient's comfort and well-being comes at the very top priority of everything we do for them. So the outdated model of decision-making in medicine is the first one you see here. The paternalistic clinician tells the patient, this is what we're doing. And, you know, everybody has those experiences in the clinic where they say, you know, what do you think about the treatment options we talked about? And the patient says, well, you're the doctor, tell me what I should do. So there are some patients that prefer this method, and that's okay. An interesting distinction is kind of between the next two, between informed medical decision-making and shared decision-making, and the two are distinct. Informed medical decision-making is when you give the patient the information and then you say, do you agree to the treatment? Which of course informed consent and informing the patient is really important, but that's not quite enough to really call it shared decision-making. Shared decision-making requires that the patient explore with you their goals, their priorities, their preferences, and then the decision is made together. So the first step is really choosing when is a good time for us to use shared decision-making, because it's not always appropriate in every clinical situation. Some places where it is particularly useful is when you've got multiple approved options for treatment. One that comes to mind is metastatic castrate-sensitive prostate cancer, and they could choose docetaxel or abiraterone or enzalutamide, and they all have obviously very different side effects, different implications on their life. And we're never going to have a head-to-head trial of those therapies, and so really it's the patient's decision when they would, which of those they prefer. When the patient has significant comorbidities or is very elderly and frail, we can't always just go by the guidelines. Sometimes the treatment that the guidelines suggest to us, we know the patient would not do well with. And in that case, we have to kind of talk to them about what alternative options are. And again, that can get us into uncharted territory in terms of guidelines and data. When the treatment is controversial, and then sometimes there's other patient factors to take into account that will really be important in the decision making. Financial constraints. I previously worked at a public hospital, and when patients don't have insurance, it can be very challenging to, give them guideline based care if they can't come follow up in your clinic, or if they don't have transportation. Those things can be a real challenge, and it's a nice idea to just say, well, we're going to go by the guidelines and do exactly what they say. But if you prescribe a treatment that the patient can't actually adhere to because of other factors in their life, then we didn't necessarily do them a service. Thinking about transportation in terms of a decision between mastectomy versus lumpectomy plus radiation therapy. If the patient lives 2 hours away and they say, I can't come every single day for radiation, in that case, I need to ultimately choose mastectomy. These other things are important for us to take into account. And our patients are whole people as well. They have other obligations other than just taking care of their health. Maybe it's a single mom who has to work 2 jobs to support her kids, and she can't be coming to your clinic once every 2 weeks for treatment checkups and things like that. She needs a situation that's going to give her more freedom from the clinic. And those are important things to take into account. I had a really challenging situation recently where a 73-year-old man with a sarcoma told me that he has a financial issue where he basically would, prefer not to get treatment because of his finances. And of course, as a clinician, we want to say, well, but you have to get treatment. You've got this diagnosis, you have to. But I think shared decision making is really about thinking about the patient as a whole person and not just as their disease, as their cancer. So a few examples here of shared decision making in oncology. We already touched on the first. In breast cancer, mastectomy versus lumpectomy plus radiation therapy. I feel like this one tends to be easier for patients. I think most women, as soon as you present these 2 options, either way, they know what they're interested in. A tougher one sometimes is with localized prostate cancer, prostatectomy versus radiation therapy, especially because the patient will see the urologist who recommends prostatectomy and then see the radiation oncologist who recommends radiation. And a lot of times, as a medical oncologist, I think some of us are kind of in the middle there, that the patient is coming to us as a neutral source. Well, what should I do? And so really having a balanced conversation with them and helping them decide what's going to be the best treatment for them is very helpful. In terms of screening, what age to start mammography, given that we've got different guidelines that say different things. Something like participating in clinical trials can be something where patients in the beginning think, well, why wouldn't I want to participate on trial, and kind of helping them come to a decision that's good for them, that they'll be able to adhere to, that, if there's a lot of follow-up that's needed, that we make sure that we give them all the information so they can choose whether this is good for them. A really important one is end of life care decisions. We have all had many code status discussions through our careers, and it seems like everyone goes a little bit differently, but this is one that patients, and particularly their families, struggle so much with, that I think shared decision making is a really important piece in discussing end of life. So the share approach is just one kind of mnemonic to remember the steps of shared decision making. And really the step 0 that we've already discussed a little is deciding when is this approach appropriate, because it's not necessarily appropriate for every clinical scenario. But once you've decided that you want to enter into shared decision making, first you seek your patient's participation. You help your patient explore the treatment options and the alternatives. We're all pretty comfortable with that part. I think the third step here is one that is a really key part of shared decision making, which is where you hear about the patient's beliefs and goals. And with that, then you help the patient reach a decision. And no decision, well, most decisions are not final. They can be revisited, and they can, you can help the patient to reflect on whether the decision continues to be right for them as time goes on. So the first step is to seek the patient approval. And this is where you go to your patient and you say, there are options. There's, medical care is complex, and there's not necessarily one right answer to this issue that we're dealing with. And that being said, your preferences are ultimately what's going to help us decide what we should do. And we need to make a decision together. This is not my decision to make. This is our decision. And I'm going to work with you to get to a decision that's going to be right for you. And, I think at this step, acknowledging that whatever decision we make together, the outcomes and the side effects and the consequences, you are the one that those things are going to occur to. So it's most important that you are on board with whatever treatment decision we make. Then you help the patient explore the options. Again, I think this is something that we're all very used to, very comfortable with, describing the options in a way that the patient can understand, describe risks and benefits in a balanced way. When we use statistics, doing something like X number of 100 patients like you are going to have a recurrence if they don't have this treatment, rather than something like relative risk of recurrence, number needed to treat, those numbers are not really always accessible to the patients. Assess your patient's values. So find out, what is it that really matters most to them? Do you care more about having more time, or about the quality of your time? And there are some patients that are going to tell you, my daughter is getting married in 6 months. I have to be there at the wedding. So even if it means less quality of life during that 6 months, I have to be at that wedding. And hearing that can really help us as clinicians plan a treatment that will get the patient to their goals. And so one decision won't necessarily fit every patient. And this is the part where really shared decision making is going to help the patient get to the outcomes that they think are important. Asking the patients what they're afraid of. When you think about your diagnosis and your treatment, what are the things that worry you? Because that can also kind of help us figure out their values and tailor our treatment plan. And this is where decision aids can help a lot, which we'll be talking about. So you help your patient reach a decision, understanding that sometimes this isn't a decision that can be made today during our 15-minute clinic slot. Maybe you're going to need to go home and talk to your family and think on it, sleep on it. And there's no pressure to make a decision right now. I think this is kind of the crux of why we like to have code conversations ahead of time, because then you can say, take some time to think about it. We're not in a situation where we need to decide this right this minute. And then continually kind of reevaluating the decision and whether it continues to be the right decision for them. For instance, after a patient starts chemotherapy and they start to experience the side effects that we've talked about, finding out from them if the benefits that we talked about pre-chemo, are they still worth it to you? Because if they're not worth it to you for the side effects you're having, then we need to come up with another plan. So decision aids can really have a lot of good outcomes for the patients. It really puts power in the patient's hands and it helps them to explore their own beliefs. When you're at the step of assessing their goals and priorities, sometimes they're like, well, I don't really know. I mean, I want to live longer and have good quality of life. And so it can be hard for them sometimes to vocalize what really is going to matter most to them, and what matters most to them can change over time. So decision aids can help to explore patients' own beliefs and lead them to the decision that's best for them. And this is something to use as an adjunct to shared decision making. This does not replace shared decision making. One of the criticisms of decision aids is that it can be hard to integrate into practice, because when you're sitting there with the patient in the clinic and you're trying to come to a decision together, you don't necessarily have the free time to be able to give them this decision aid to work with and come back later and get the answer from them. Where I see decision aids being most helpful is when you've had this discussion in the clinic, you can tell that they're really just have not been able to come to a decision yet. And so when you're basically saying, maybe let's table this conversation, come back to it next time, or take a couple days to think on it, I'll give you a call on Friday. You could suggest to them to use a decision aid. This one that you're seeing here is from a study that was looking at adjuvant therapy for colon cancer. And you can see basically that it's just very visual. And for a lot of our patients, the discussions that we have with them in clinic, especially when things are emotional and a diagnosis is new, a lot of it may not be remembered later. It was kind of in a fog, in a haze that all happened. So here they can sit down with it later. It's visual. It can help them to really find out what their preferences are. So this one I'm going to take you through now is the decision for lumpectomy versus mastectomy. And this is on healthwise.net. They have a number of these decision aids. And so it kind of takes you through a number of steps. The first step is that they give some information. The second step is weighing some pros and cons. This part I think is nice, the third step, and there's more to it than what's here, but this is an example. Actually having them kind of click, and on a scale of 1 to 10 here, most important to least important, they have the patients actually select how they feel, and that can kind of help them too when they're not under pressure to make a decision as much as to explore preferences. It can help lead them to the decision that's right for them. And so then after they've kind of gone through all of that, rather than saying, okay, which one are you going to do? It says, which way are you leaning? And there's a couple steps afterwards where they give a summary. And so then this can kind of help the patients to get out on paper, so to speak, which way they're leaning and what they think their decision is. So some of the benefits of patient aids, there was a systematic review that showed that it increased patients' knowledge about the options. It made them feel more comfortable with their choices. It prompted them to take a more active role in their care. It reduced stress, anxiety, and decisional conflict. And we know so many of our patients are really anxious, under a lot of stress about their diagnosis and about their treatment. And so anything that we can do to kind of help relieve that burden is a benefit. So some of the physician perceived barriers to shared decision making, time constraints, I really think is number one. These conversations take time, and we don't always have that luxury in the clinic. And so learning to kind of do this within your time constraints of allocating a little extra time in a visit where you know a decision needs to be made can help to make this process work. The perception that patient characteristics are not conducive, and I think some of that may be patient willingness, the idea that maybe a patient doesn't really want to be a part of their own decision making. And I think you only know that if you ask them, which we're going to discuss a little bit more. The nature of the clinical situation, if there's clearly one best next step and it overall fits with the patient, perhaps that's a time where shared decision making could seem less important. But again, all those patient characteristics of what is their financial situation and what obligations do they have at home and what is their transportation situation, you may not know those until you probe. Insufficient training, high workload, all of these things can be a barrier to shared decision making. But the outcomes for patients are improved with shared decision making. They have greater satisfaction with their treatment, improved mental health. They feel more trust in their provider. So really, it has a lot of benefits for the patient and how they perceive their interaction with you and the healthcare system as a whole. So this was a study looking at lung cancer patients who were being evaluated for adjuvant chemotherapy, and asked them, what is your preferred role versus what is your actual role in the decision making? And it seemed like in general, the two lined up pretty well. Most patients thought that their actual role was also their preferred role, and most of these patients preferred collaborative approach. Almost half of them changed their preference after 6 months of treatment for what role they would like to be in, but half wanted to be more active, half wanted to be more passive. Older adults actually seem to have more of a preference for an active role in their decision making, particularly those who were widowed and live alone. And some of the priorities they talked about included, doing everything to help my health, following their doctor's recommendations, quality of life, and living longer. And really what a number of studies have found is that the concordance between the desired and actual role is what's most important. So if you have that patient who says, you're the doctor, you tell me what to do, they're telling you that they want a more passive role, which you can probe further. But if they truly do want a passive role, they're going to have greater satisfaction if you do make this decision for them, which can always be reevaluated in the future. On the other hand, when there is discordance between what role the patient would like and what role they actually have, they have not only lower emotional quality of life, but physical quality of life, according to this study. So I think really the main point here is to get your patients involved in the discussions that you're having around decisions, to find out from them, what role do you want? Would you like us to make decisions together? Do you want to be the main decision maker? And listen to them when they tell you things like, I already know what I'm going to do, or you're the doctor, you tell me what to do. They're telling you about their preference for their role, and it's important to pick up on that, clarify that, and then respect that. To look for the situations that are appropriate for shared decision making, and then make sure the patient wants to participate, and to help with concordance between desired and actual role to increase the patient outcomes and how they feel about their experience with you and the healthcare system as a whole. Thank you.